Glaucoma is the leading cause of blindness in the world, including partial visual loss. It affects 3.5% of the world population from ages 40 to 80. Estimates show that number will reach 111.8 million by the year 2040. Microinvasive glaucoma surgery is a recent surgical technique for reducing the IOP for glaucoma patients with mid to moderate level symptoms due to its much lower burden on the eye and shorter operating times with far less complications. This technique is widely praised. This surgery uses several instruments, one of which we developed, specifically the TMH, a microhook for ab interno trabeculotomy. A straight version with a total length of 126 millimeters is suitable for the temporal approach to the nasal meshwork and for the superior approach to the inferior meshwork, and the left or right version for the nasal approach to the temporal meshwork. There are several other hooks for trabeculotomy surgeries, but the TMH has a smaller tip, small enough to enter directly into the Schlemm's canal. It is sharper too, so the trabecular meshwork can be easily incised by moving the hook circumferentially. The spatula-shaped microhook makes it easier to insert it into the Schlemm's canal without the need for creating an entry site. This both simplifies the surgical procedure and shortens the time. The left or right TMH is inserted into the Schlemm's canals from the nose side. It is designed to incise the trabecular meshwork from above and below at 60 degrees respectively. The straight hook is inserted from the temple side and incises the trabecular meshwork above and below at 60 degrees. Total incision angle then becomes 120 degrees. This shows how the TMH is used in this surgical technique. After injecting OVD into the anterior chamber to stabilize, with a gonioprism lens to observe the temporal angle, the tip of the microhook is inserted directly into the Schlemm's canal and moved circumferentially to incise the inner wall of the Schlemm's canal and trabecular meshwork. Here are the tips for the TMH. When inserting the tip of the hook into the Schlemm's canal, in order to minimize damage to the outer wall of the Schlemm's canal, it is recommended that the meshwork be perforated by gently sliding rather than stabbing. To avoid unintended tissue damage around the trabecular meshwork, the correct insertion, direction, and depth of the tip of the hook should be monitored carefully during the procedure. This shows the TMH's post-operative results in 560 eyes with glaucoma. As shown here, the IOP lowering effect of under 18 millimeters mercury in 2 years was 58%, and under 15 millimeters mercury was 40%. In conclusion, trabeculotomy with a TMH has a good IOP lowering potential in patients with glaucoma. The non-inferiority of ab interno microhook trabeculotomy using TMH to incise the trabecular meshwork to trabectomy surgery was analyzed in terms of the 1-year post-operative outcomes of Japanese patients with glaucoma. The surgical success at 1 year after surgery was defined as IOP between 5 to 21 millimeters mercury, reduction of 20% from preoperative IPO without any additional glaucoma surgery. The paper concludes that the surgical success of trabeculotomy at 1 year after was not inferior to that of trabectomy surgery.